So revision surgery, it's a kind of newer epidemic. And so interestingly, when we first did the internal brace, I remember talking to Schick and Tony and John and George and Neil and Chris and some of these other people about it. And nobody was ever saying, hey, this is a bad idea. Everybody kind of said, this may be a good idea, but I think everybody was excited about the possibility that this could improve the outcomes of revisions. That was something in 2012, 13, 14, as we started doing this over and over and over at meeting after meeting. Have you done any revisions? Have you tried it on a revision? Have you done it in a, because everybody knew the revisions are just terrible. So and the answer at the time was no, I had not. I had not gone there yet and done it for a revision. So this will teach you to listen to the hand weenies. So the hand guys put out, there's a publication in the hand journal. I'm kidding. Yeah, our hand surgeon is a stud. But they published this in the journal Hand Surgery. The incidence of primary UCL reconstructions among professional baseball pitchers is increasing. However, the rate of reconstruction requiring revision is decreasing. That seemed as backwards as anything that any of us that deal with baseball had ever heard, because that was in the time frame where we really were seeing a lot of explosion of revisions. And the outcomes were not particularly good. So this is a publication based on some of the data that Neil and Josh and Dave came up with. It was 26 pitchers with 2-year follow-up, a total of 31. Only 42% returned for greater than 10 games. And that's just about as bad an outcome as you're going to see in something that we actually do. A 21-month recovery average. And their careers went from, about 5 years after primary to about half of that with revision. So no positive actually came out. If you want to talk about a study that had no real silver lining to it, this is one of those no silver lining papers. And then Chris and a lot of the same people looked up, and this really became the salient article on revisions, undoing kind of the thought that the trend was going in a good direction from the Hand Society article. A trend was seen towards increasing number of revision surgeries over time. And I'd be interested to hear if Chris got any blowback from the hand surgeons that published that. But I think clearly we all knew this was going in the wrong direction, and Chris and company put this out. So this is kind of the big deal study. 69 pitchers over a 6-year period, 7 seasons. Average age 26, about a little over a third of them were major league pitchers. 77% return to play, but only 55 at the same level of play. It was an 18-month recovery with a mean career length of 1.7 years. And there was no significant difference in between the major and minor league groups. So this is a bigger group, and definitely seeing an increase in revisions. So what's the problem? Well, the problem is that the outcomes are bad. No matter how you slice it, the outcomes of revisions are just terrible. And these articles were all published anywhere from 2008 to 2019, but there's no silver lining to these things. So they have shorter post-revision careers. There's decreased workloads, decreased performance, high complication rates. And so after talking to all of my colleagues that were asking about revisions, I started doing these with the internal brace in 2017. And just to give you some background, I have not done a single revision reconstruction since I did this the first time. So since 2017, now going on as 8 years plus, I have not put a graft on top of a graft since 2017. The total number of revision cases I've done is 44, but I wanted to look up a group of them, and I chose this for a reason. And I wanted to look at the ones that were Division I and higher. And I chose that because most of these athletes had their primary UCLs done by talented elbow surgeons that do high volume. And I did not want poor tunnel placement to be a confounder of the revision. And I think that anytime you're doing revision anything with bone tunnels, you are somewhat at the mercy of the previous bone tunnels if they're not good. So I didn't want to do any outliers. We will publish a larger series of revisions. But my assumption was that all these people that were D1 and higher had their UCLs done by a lot of the people that sit in this room, and they were good, well done. Tunnels were well positioned, grafts were well chosen, rehab properly, all that. So I wanted to take as many variables out as possible. So I wanted to take out as many confounding variables. So it's a pilot series, single surgeon, minimum 1 year follow up. The average was just under 3. And we looked at it over a 6-year period. I used a little bit larger anchor on the humeral side. This speaks to the bone problem. When you've done a reconstruction, you've got a little bit more soft tissue in the humeral tunnel. I wanted to make sure I got good purchase, and I didn't want the previous tunnel to affect the repair. I used a burr, which I have now gone to having open in every single UCL case, especially when they have a proximal injury. I want to take a burr and I want to make sure I get a bleeding surface. So I will hold the ligament open with the split with a hemostat, and I will take a high-speed burr and make sure that that bone bleeds before I either repair it or reconstruct it. So I'm doing that on every case. But I got that from the revisions. I use a standard 3-5 anchor when they're torn distally. So we had a lot of UCLs, and it boiled down to 10. So 14 were eligible, and we got 10 of the 14 back. And so the average age was 25. We had about 3-year follow-up. The tear characteristics, 60% of them were high-grade partial, 40% were complete. About 80% of them were proximal, which is where I think most of us would say we see the vast majority of these re-tears. And there was about a 20% distal. There were some periligamentous calcifications, which I suspect are more post-op than enthesophyte type of problems. The KJOC scores, the ASES scores, all of them improved. The Andrews-Carson score, they all got better. This is kind of a typical case. 39-year-old, this is, and I have his permission to say this is Rich Hill, who, interestingly, I use him as a case because Andrews and I did his primary reconstruction in 2011, and Rich has basically played for all 30 major league teams, I think, over the course of his career. But he pitched 7 seasons at MLB since his primary reconstruction, had the onset of symptoms in 2019, couldn't complete the season. So this is the tear, and this is a pretty, this thing doesn't work, but this is a pretty typical appearing re-tear. You can see there's a enormous mass of tissue that appears well attached on the ulnar side and completely off, I mean, another county on the medial side. So there's not much debate. Not too many people are going to read that and say that's intact. So he said, he was 39 at the time. He said, I don't have time for 18 months. I want it repaired. I'll take the risk. If it doesn't work, it doesn't work. I'm 39. I don't have 2 years to get back. Easy peasy. It didn't have to, that's a low level conversation. It took me about 45 minutes to dig his nerve out of the concrete that it was in, that Andrews and I did back in 2011. And then this big hole in the middle of his ligament. I used a 4-5 anchor. I used the burr. I did everything we just talked about, and I did the internal brace. And the right-hand slide is essentially the same cut. And you can see that it's completely healed back. There's no separation. I think the burring of that bone probably makes a little bit of a difference, but it's a really strong repair, as we've heard all morning about the biomechanics. But I think the key is you got to get it to heal. The strength of the repair at time 0 is important, but ultimately we're talking about biology here and creating a biologic environment for something to heal to where it's already been used, where you've already got stuff in the tunnels. The ligament doesn't necessarily heal to the bone. The bone heals to the ligament. The healing properties come from the bone itself. If they came from the ligament, we would never have to fix these things. So I think we got to create a bleeding environment. So all 10 of them returned to play at the same or higher level. 2 got drafted post revision. The average return time was 9 months, and 1 player went from a starting to a relief role. There were no reported complications. Most of them had minimal ulnar nerve distribution dysesthesias. And just to piggyback, since I am on the microphone, I think that dysesthesia that resolves within a couple of weeks should no longer be considered a complication. I think that every single one of them has that. So if you want to say that, then we have a 100% complication rate. No patients returned to the OR in the postoperative period, and there have been no reported failures among this group. And we actually just recontacted them for the ones that are still throwing. So the limitations are it's a very low case series. We just submitted this and it just got accepted for publication. So it should be out. I think it's in OJSM. It'll be coming out sometime in the spring. Small number of patients, and there's obvious selection bias, which I absolutely accept that I biased the patient group, but I did it for a good reason to make sure we weren't confounding. So I think that repairing these with the collagen coated tape, it's really fiber tape, not suture tape. Again, there's a difference. Shorter return to play than most revisions, more reliable and lower complication rate. I think we need less stringent follow-up inclusion criteria. I'm going to publish on the larger series. So my opinion, internal brace for revision UCL is here to stay. I actually think it may be one of the best things that came out of this whole experience of creating this idea. Hybrid options, I think, are going to continue to evolve, as we've heard for the last hour or so. And we all know that there are limitations, where the iterations of these types of procedures fit, distal versus proximal, all these different things. Revision of primary repair to full reconstruction is really not a difficult operation, and we really aren't that limited from a reconstruction standpoint. They're very similar to primary reconstructions in that you have great bone to work with. It's really, I think we should see the outcomes of these operations being very similar to primary reconstruction. And I would expect that because of the minimal bone loss from repair. Primary UCL surgery using hybrid techniques is going to have mixed benefits in the revision setting. I've encountered this with increasing frequency as the hybrids have been around for a little bit longer. I think that where there's an anchor in addition to a tunnel on the medial epicondyle side, that's a problem. Now you're dealing with less real estate to deal with. So a tunnel in addition to an anchor on the medial epicondyle side, I have found problematic in terms of getting a really good fixation. I'm using a bigger screw on those. On the ulnar side, I don't think it's as big of an issue because I think you can go a little bit more distal on the ulnar side and still get a good tunnel. But I think that the hybrids are going to create a little bit of an issue on the proximal side more so than the distal side.